morning all. Sorry about the mix-up of the talks. I'm HUMAYUN BAIG from Melbourne, Australia. Now, I met my good friend Dr. Chandran Abraham yesterday, and he told me, oh, you're going to talk about this IgG4 related disease. And in 30 seconds, he summarized all the salient points. And I told to myself, bugger, he knows it all. So I hope I'm not carrying cold to Newcastle. The nomenclature of IgG4 related disease and the criteria for diagnosis was set about by a group of panelists who gathered in Boston in 2011. And in 2012, they wrote in Modern Ophthalmology outlining the criteria for diagnosis. Basically, it's a newly recognized fibroinflammatory condition which is typified by tumefactive lesions at multiple sites. Virtually any organ can be involved. You can almost think like sarcoidosis, except the histology is quite different. And it's characterized by dense lymphocytes and plasmacyte infiltration. A typical fibrosis described as storiform fibrosis. Storiform is just a description. It looks like a cartwheel appearance. Obliterative phlebitis and eosinophils is another character. So to exemplify that, I came across a bilateral lacrimal gland enlargement case. She's a 71-year-old diabetic woman who had swellings in both orbits of 6 to 8 weeks duration. It was not tender, firm to palpate, and quite easily visible on retraction. So she was sent for a CT scan, which confirms bilateral lacrimal gland enlargements. Now, we lost touch of her because she was meant to come back and see us, but she developed some other things. She noticed a lump in her left axilla, and the general practitioner was concerned whether it could be a lymphoma. She promptly referred it to the oncologist. The oncologist confirms, yes, it is a lymph node, but he looks at the orbits with swellings popping out like golf balls. So he wanted to tie it up together. He was looking for other possible causes, including Sjogren's, sarcoid. So he does a whole lot of investigations which were all negative. Then he takes a biopsy of the lymph node, and the pathologist comes out with a very comprehensive report saying it is an IgG4 related disease. So I was in the dark when all this was happening, so I rang up Stuart Rock, my pathologist, to enlighten me a little bit about this. He said, come over to my office, I'll show you the slides. So I did, along with my research assistant, Jessica Boyle, who helped me in preparing the slides. So before he started, I had to confess to him that I hadn't seen a pathology slide for a long time. He said, don't worry, just sit down. This is the first slide he showed me. And he said, you should be able to recognize this is a lymph node structure. So you see the lymph follicles with germinal centers, with the mantle zone around it. And he also said, look, it's the normal architecture is maintained, but the space between the lymph follicles is enlarged and is infiltrated with lymphocytes and plasma cells. And he also pointed out this excessive fibrosis, which you don't see in a normal lymph node. And and I didn't know what a plasma cell looked like. So he showed me in a higher power, where the black arrow pointing at a plasma cell, and you can easily see there are plenty of plasma cells there, and one in the white arrow is an eosinophil. So when there are so many plasma cells, he said I had to look for other things, so he did special immunohistochemical staining for immunoglobulins, and that was a non-specific stain. Then he went on to stain them specifically for IgG4 immunoglobulins, and you can see, lo and behold, all these plasma cells are lighting up. When you see more than 50 plasma cells in a high power field, you can confidently say it's an IgG4 related disease. In this case, there are more than 100. Not only that, serum IgG4 level was quite elevated. So that in short what his report was. That's exactly what I showed it to you just a minute ago. So what are the presentations of IgG4 related disease? It's quite incredible that we have known about most of these diseases by different names, quite unrelated we thought, but they're all clumped under the heading of IgG4 related disease. The most prominent one is the autoimmune pancreatitis type 1, which is common in the Japanese. The swellings of the lacrimal gland, other exocrine glands, which we have known as Mikulicz disease, which was described more than 100 years ago. It all comes under this topic. The isolated submandibular adenitis, cutaneous tumor, and with the orbital disease, the so-called pseudotumors, inflammatory pseudotumors. If you are able to do biopsy, at least 25% of them will be an IgG4 related disease. Retroperitoneal fibrosis, the idiopathic, which constitutes more than 70%, is now recognized under this category. The pathogenesis itself is poorly understood. There is no specific autoantigen which has been identified. You also have to understand that IgG4 antibodies themselves are not pathogenic. It probably represents a down-regulatory response to another primary process. And the elevation of serum IgG4 again is not really specific. Is it an allergic response or is it an autoimmune response? There is no definite evidence for that yet. The current thinking is that probably the role of CD4 plus cytotoxic T cells, because they seem dispersed throughout the lesions, and they make products like granzyme, perforin, interleukins, and all these cytokines are continuously presented by B cells and the plasmablasts. The plasmablast, in fact, is a better biomarker, but it's not easy. Not many laboratories have the facilities to measure the plasmablasts. So what is the principles of treatment? All patients with symptomatic disease need treatment. Glucocorticoids is the first line agent, and quite often they require maintenance therapy because relapsing cases are not unusual. And you can later on add steroid sparing agents like azathioprine. In resistant cases, rituximab has been found to be helpful. There are multiple organs involved. I can't go through them all. Whether it is kidney, lungs, meninges, everything you can think of can be involved. this is the same lady 2 weeks after starting her steroids, is almost gone. So what are the things we can think of? We've touched upon that. Now, before I finish, I want to highlight a few of the college events we host in Australia. RANSCO stands for Royal Australian New Zealand College of Ophthalmologists. Our annual conference this year will be in Adelaide. Next year it will be in Sydney in association with the Evisceration and Pediatric Society. In 2020 in Auckland, New Zealand, we'll have the APAO. But the big one, the World Congress, is going to happen in 2022 in February, so exactly about 4 years from now. You can mark it in your calendars. It's going to be a fantastic scientific session. And come with your families, spend a few weeks there to look at Australia and New Zealand. It's a fabulous place to see. One of the most beautiful places will be New Zealand, the most unspoiled countries in the world. That's our Flinders Street station in Melbourne. Melbourne Cricket Ground, early in the morning. So I thank you and everyone. Thanks to the organizer for giving me an opportunity. I'm really privileged. Thank you very much.